Hello. I would like to thank the organizing committee for requesting me to give this talk. And I shall be talking about TARGIT IORT, Targeted Intraoperative Radiotherapy for Breast Cancer. This is the writing committee, and these are the names of all the authors. And I would like to acknowledge every clinician and every patient and every team in each of these centers who participated in the Target A trial, without whom and without their tireless efforts, none of this would have been possible. This is the International Steering Committee and the Trial Steering Committee. So these are all the authors of the Target A papers. These are my potential conflicts of interest in terms of a project grant from NIH RHTA and some honoraria and travel reimbursement from Carl Zeiss. So more than 20 years ago, 25 years ago, when I was 30 years ago, really, I was treating patients in Tata Memorial Hospital in Mumbai. And there I would tell a patient, you have breast cancer. And the next question I had to ask was, can you actually stay in Mumbai for 6 weeks after the operation? And if they said yes, I would say, well, we can preserve your breast. But if they said no, then we would have to say we have to do a mastectomy, because the whole package deal is to do lumpectomy and whole breast radiotherapy. And this was not a problem limited to Bombay. It is a problem in Americas. It is a problem in Australia. It's a problem in Europe. And even in the UK, you can see these red circles. They are 13-mile radii beyond a radiotherapy center. And you can see even in the UK, there are large areas, green areas, where patients need to travel more than 13 miles for taking their radiotherapy. So this was a big problem. On side by side, this is the rationale and development of the IORT technique. So this concern about patients was then combined with the findings of whole organ analysis of mastectomy specimens, in which I found that breast has many other microscopic foci, even if they were not seen on imaging techniques. But despite these other foci, more than 90% of recurrences occur around the primary tumor. Therefore, the hypothesis was, why treat the remaining breast, just as we don't treat the other breast? And we presented this in 1995 and published in the British Journal of Cancer, and suggested that we should try and focus radiotherapy only to the area around the primary tumor. So we developed the target technique with this idea in mind. You can see here the operation being done in the first operation on 2nd of July, 1998. That's how it looks in the operation theater. And that is Professor Michael Baum and Professor Jeffrey Tobias, with whom we developed this technique. Now, as you know, for breast cancer, early breast cancer, most of the treatment is completed by the surgeon. So that's a specimen with the wire and the completely excised. But we still need to give radiotherapy to reduce the risk of local recurrence. And this is the way I'm describing the technique. So you can see here how the tumor bed, the green tumor bed is there, and you can put a purse string suture at the right place in the depth of the wound. And you can see how it looks here. So the purse string is taken at the correct depth so that it is not too close to skin and it's not too deep, because if it's too deep, then some part of the tumor bed will not oppose the applicator surface. And you can see how when the purse string is tied and the applicator is inserted, you can see how that looks now. That's the place where the applicator is supposed to go in. And you can see how, if it is, this is the place to put it, the red circle, that's the correct place for the purse string in the lower part of the diagram. So this is done during COVID times. You can see my gear that I use for COVID, and that's how it looks in the operation theater. And that's how the rest of the operation theater staff are protected using these lead shields. Now, in this particular patient, the histopathology showed that it was a completely excised cancer, and she had already had radiotherapy, so she didn't have to come back for any further radiotherapy at all. So radiotherapy is delivered immediately after lumpectomy. It is focused radiation to the tumor bed. It targets tissues at highest risk of local recurrence and avoids normal structures such as the heart and the lung. So it is based on the principle of precision and immediacy. It is individualized according to size of the tumor bed. So you can choose applicators from 1.5 centimeters to 5 centimeters in size. We published how the technique is done in 2002, and we published the first results of first 25 patients in Annals of Oncology. Following which, we started the Target A randomized trial, asking the question, can risk-adapted single-dose Target IORT during lumpectomy for breast cancer effectively replace the standard usual fractionated postoperative radiotherapy regime. And the recruitment started in March 2000 and finished in June 2012. You can get more information on this website, targit.org.uk. So 2,298 breast cancers who were scheduled to have a lumpectomy were randomized. The eligibility were very wide, more than 45 years and suitable for breast conserving surgery. They had to have invasive ductal carcinoma. MRI was not required. Patients from 10 countries and 32 centers participated. It was random allocation to target or IORT or EBRT. If they were randomized to target IORT, they had lumpectomy and single dose intraoperative radiotherapy under the same anesthetic. And 20% of these patients we expected postoperatively to find some factors. Now, these factors were invasive lobular carcinoma or positive margins mainly, and or extensive interductal component, but that was taken away later on, not much used. So if these two factors are found, they were given whole breast radiotherapy, and this decision was left to individual trialist centers. Whole breast radiotherapy was the control arm. The first publication was done in The Lancet in 2010, and the second publication, including survival analysis, was done in 2013. So we were waiting for longer follow-up, and while waiting for this, we did studies on other obvious benefits of using target IORT. Firstly, cosmetic outcome is superior with target IORT. This has been shown time and again in various parts of the world. Quality of life is superior with target IORT. These are studies from Germany as well as Australia, which show that radiation-related quality of life and cosmetic outcome is better with target compared with EBRT. Also, there is less pain, less breast-related and arm symptoms with target IORT. And this is a study from Copenhagen, which clearly shows that quality of life is better with target IORT for breast cancer. What about patient preference? It has been shown in trials in studies in USA and in Australia that patients prefer to have target IORT, and doctors would prefer to have target IORT if they were patients. And this is despite the possibility of a higher local recurrence rate, which eventually has not turned out to be the case anyway. Very importantly, target IORT is cost saving. In the US, it is expected that over 5 years, using target IORT, you would save $1.4 billion. And in the UK, the amount is smaller, but it is still cost effective. About £9 million in the UK are saved because EBRT is less expensive in the UK than in the US. For the patient, IORT reduces patient's travels to the hospital. So the journey literally is reduced. And this has an environmental impact and social impact, because many times your relative doesn't have to take you to the hospital every day for several days, for several weeks. And imagine patients have to do such journeys through every day, sometimes for 1 hour, sometimes for 4 hours, because they stay far away from the radiotherapy center. And in the UK, on an average, if patients have IORT, 753 miles of travels is saved on an average. And this also reduces carbon footprint, and therefore target IORT could reduce global warming because breast cancer is so common. Biologically, target improves tumor microenvironment. What is scary is that after surgery, wound fluid, which collects in the wound, actually stimulates proliferation, motility, and invasiveness. And this was a study from Italy with Dr. Samuele Massaruth and Dr. Baldassare. But what was the good news was that if patients have received intraoperative radiotherapy, if they receive target, then this stimulation of cancer cells by the wound fluids is abrogated. There are fewer invasiveness, there are fewer its motility is reduced, its proliferation is reduced, and its invasiveness is reduced. So this could improve the radiobiological effect of target IORT. So the targeted randomized trial, here I'm going to tell you the long-term results. So these long-term results are important. So what we did was the first patient was randomized in year 2000, and the last data lock for this analysis was in 3rd of July, 2019. And we set the bar high for completeness. We said that the follow-up would be considered complete only if 95% patients had at least 5-year follow-up and 90% patients had at least 10-year follow-up or were seen within the previous year. So we raised the bar very high, kept the trial unblinded until this bar was raised, and it was unblinded only when the follow-up was complete. And this was possible because of collaboration with everybody around the world and this surgical interventional trials unit trials team in London. So after the follow-up was complete, the database was unblinded, and you can see how close the expected follow-up and actual follow-up are close to each other. Because of this, Target A, when it was published, was the largest amount of follow-up data amongst all partial breast radiation trials in invasive breast cancer. You can see in this graph how Target A stands tallest when you plot amount of follow-up time for each follow-up period in all partial breast radiation trials for invasive breast cancer. This is published in the BMJ. So this is a randomization. The two randomized arms were similar to each other. Importantly, age and BMI, which are risk factors for cardiovascular deaths as well as cancer, were similar to both sides. So that's an important finding here. And all other tumor factors were also very similar to each other. So we have seen the obvious advantages of Target. There is surgery and radiotherapy is completed at the same time. There is less travel. There is good cosmetic outcome, less pain, fewer complications, and lower toxicity. Now, what else does a patient want? Patient will want to know, yes, what are the chances of this cancer coming back in the breast? And this is the results. So look at 5 years. The purple dots here show patients who are alive and well. So most people are alive and well. 94 out of 100 people are alive without local recurrence in each arm of the trial. There is one more local recurrence and one less death. So the results are exactly similar. When you look in long-term outcomes, these are 12-year data. And in 12 years, local recurrence-free survival and invasive local recurrence-free survival was not different from each other. Mastectomy-free survival and distant disease-free survival was not different from each other. And breast cancer mortality was no different from each other. So in terms of breast cancer control, risk-adapted single-dose Target IORT had results which were comparable to fractionated standard postoperative whole breast radiotherapy. So this was an excellent result. But and the bonus of it was this, that non-breast cancer mortality was less. It was nearly halved from 5.85%. It is reduced to 5.85. So this was non-breast cancer mortality was reduced with hazard ratio of 0.59 with a p-value of 0.005. And overall mortality curves, as you can see, the mortality in EBRT arm keeps remaining higher and keeps on going higher as time passes. So this is a summary slide which shows all the main results. So no difference in any breast cancer outcome and a significant reduction in non-breast cancer deaths from 9.85% to 5.41%. A difference of 4.4%, which is substantial. And for such a difference, any drug would be used in every patient. You can scan the barcode there with your camera. While you're watching this, you can go on the Target IORT website, and you can see all the publications related to this year, and that will be shown again and again. So in year 2000, we had the first patient randomized. In 2010, Lancet put our conclusion on their front page masthead, and that conclusion still stands when we published the results in the BMJ in 2020, that breast cancer control is comparable to whole breast radiotherapy, and there were reduced deaths from other causes such as cardiovascular problems, lung problems, and other cancers. So it should be considered as an alternative to external beam radiotherapy delivered over several weeks. So this was covered greatly in the news, came the front page of the Times above the fold, and you can see there it is. And I shall now discuss a few interesting points. So please give your comments by going on to this form and by clicking on to scanning on this. So please give your comments and let us know if you're interested in using IORT, because you could take part in Target B trial as well. So some important points. There is reduced mortality with IORT, and this is plausible because within 6 months of whole breast radiotherapy, you find changes in the vasculature. The perfusion defects are seen within 6 months. And this is a study from Oxford, from early breast cancer trialist group, which found that 23% of smokers who have external beam radiotherapy will die, not just get lung cancer or heart attack, but they will die at 30 years. A 50-year woman by 80, 23% of will die. This is 6% more than what would have happened if they didn't get external beam radiotherapy. And these are smokers. And because of smokers, this risk is increased. So I believe it's unethical when it's possible to offer target IORT, to offer such patients external beam radiotherapy, because the benefit of giving external beam radiotherapy will never overtake in early breast cancer patients the 6% increase in mortality caused because of external beam radiotherapy. Other important point is that Target had a substantial high-risk population. It was not similar to other PBR trials or trials of no radiotherapy. 85% of patients were under 70 years of age, 20% patients were grade 3 cancers, 22% had positive nodes, and 19% had ER or PR negative tumors. And most of these patients actually received Target alone. They are much higher risk than no radiotherapy or other PBR trials. So for example, the PRIME2 trial, there were no patients under 65, 2% were grade 3, there were no node positive and ER negative. At 10 years, they had a 10% local recurrence rate compared with 0.1%. And perhaps this is the reason why their benefit from no radiotherapy was nullified because of this increased local recurrence risk. Whereas Target, as you've seen, has got medium risk population. This is true in terms of the fast forward trial as well. There are medium risk patients, and there is still scattered irradiation to vital organs. These are patients who are given whole breast radiotherapy, which I believe is not a forward step, but a backward step when you can reduce the amount of radiation to such patients. They have higher toxicity. 25% of patients report a hardened or firm breast. And this is something which is consistent with the physician-assisted assessment of firmness of the breast. They only have 5-year follow-up data, and I believe these side effects may be even worse by then. And they did not find any benefit in terms of mortality reduction. Whereas for Target, with very similar population, and the recurrence risk with Target was 2.1%. At 5 years, this was exactly same as the control arm of the fast forward trial with similar patients. But with Target, there are much fewer complications, less toxicity, less travel, better quality of life, and less pain, and a follow-up is much longer. Comparing with other forms of partial breast radiation, you can see how brachytherapy, look at this photograph. This is how patients should be shown they would be going through if they have partial breast radiation with brachytherapy. With external beam radiotherapy with rapid and input low and NSABP, they are low-risk patients. They required external beam radiotherapy, multiple visits to the hospital, and there was still scattered irradiation. With Target, of course, none of these problems are there. We have written about this in Nature Reviews Clinical Oncology, in British Journal of Cancer, and you can have a look at this by scanning this. This is a paper which summarizes all types of partial breast radiotherapy and is a succinct summary of the results of the Target A trial and any points that have arisen since then. I'll tell you some real-world data here. This is from France, 200 patients, 5-year local recurrence rate, 2.5%. These are all prospective studies from individual centers. So this is from Cleveland Clinic. This is from China, a single center with the higher risk patients, and they had very similar 5-year local control rates for Target and EBRT in a propensity matched analysis. This is a study from St. Petersburg in Russia. They have now treated over 1,200 patients, and their recurrence rate at 3 years was 1.5%. This is a large prospective Target E study presented in Astro, and where it clearly shows that for these 541 patients from 4 countries in Europe, the 5-year local recurrence rate was only 1.5%. So this was excellent outcomes in terms of real-world evidence. So this is another study from France, from 3 centers in France, 676 patients, median follow-up of 54 months, 5-year local recurrence rate of 1.7%. So we have real-world data in addition to the randomized trial that shows that the outcome from Target IORT is excellent. The Elliott data has been recently published, and I would like to explain how Elliott is very different from Target IORT. As you can see in this, this is the cancer being removed. That's the excision. After the purse string is taken and the spherical applicator inserted, it is done with no tissue dissection. Radiation is delivered to fresh tumor bed from within the breast, and there is higher linear energy transfer. Whereas with Elliott, you need to do extensive tissue dissection, which leads to hypoxia of those tissues and trauma, excessive trauma could cause more local recurrence. These tissue is then approximated with a lead shield placed behind the breast. And then electrons are given with a large applicator between 4 to 12 centimeters. Target, the size of applicator is usually 3.5 centimeters. This is a 12 centimeter applicator, such a big hole in the breast, and so much extensive dissection. And when the radiotherapy is given, it is given to tissues which are partially deoxygenated, which we know reduces the efficacy of radiotherapy. This is probably why there was a large increase in local recurrence with Elliott. And it should not be confused with target IORT. Although both are given during the operation, it doesn't mean they're the same thing. They're very different from each other. We can use target during ankyloplastic breast surgery, which all of us are now practicing. So these are 149 patients where this is how you do the IORT, and then we do the oncoplastic surgery and close it. So then you know where exactly the tumor bed was, rather than giving it afterwards. And this paper published from Germany, in which we have used target IORT as a tumor bed boost. And here it looks as if it improves not only local control, but it improves overall survival as well, probably by an abscopal effect. So this is going to be tested in the Target B trial. Target A is now published. It's being used as standard. Target B is in those patients who are younger patients, younger than 45, or with severely high risk factors, where we are going to substitute the boost with the intraoperative boost and give whole breast radiotherapy as well. This is a superiority trial, and we are currently randomizing in 38 countries. 1,360 patients have been randomized, and we are open to recruitment. If you want to participate, please let us know and scan that so you can come to see us. This is the trial which will test for superiority of target in terms of local control and possibly survival. So in conclusion of this Target A part, is risk-adapted IORT during lumpectomy achieved comparable long-term cancer control as whole breast radiotherapy. It reduced non-breast cancer mortality. It is better quality of life, cosmetically superior, less pain. It's more convenient for the patient with less travel time and lower cost to the patient and the healthcare system. And these data should make it available to all patients wherever it's suitable and wherever it's possible. It is actually cheaper to the healthcare system to give it. The first time we presented this was in 2012 in San Antonio, and some of you might have seen this. And we've had several meetings all around the world every year where we're meeting with the users groups, and many of you might have attended these meetings from all around the world. NICE recommended IORT in those centers who have the equipment in 2018 in the UK, and this received quite a lot of publicity. We continued having our meetings, and recently a paper in which some of you might have contributed to is under review and is published as a preprint, in which we have shown that to date, 45,000 patients around the world in these centers have been received target IORT in 260 centers in 38 countries. So it is being used all over the world. You can click there for more information. The last part I want to show, this is the study published on 9th of March, where patients over 65 were asked whether you would want to have either surgery just without radiotherapy or IORT or whole breast. And 75% of the patients chose to have target IORT. And patient choice is important. In the UK, it is the law. So it's the law that you should give all the options to patients. And if you don't give it, then you break the law. So people are inadvertently breaking the law if they don't inform patients about target IORT. I leave you with this patient.
I'm Marcel Bernstein. 8 years ago, I was diagnosed with early stage breast cancer. I had it for 2 months only before I was cured. I had target IORT at the same time as the operation to remove the cancer. I spent 1 night in hospital and I was back at work within days. No pain at any time, no complications, no scarring. I can't even tell where on my breast the surgery was. And no recurrence. 8 years. And that isn't just me being lucky. Studies show that my experience is similar to that of other women who've had target. I am so happy I was able to have this treatment.
So target has been used in 45,000 women around the world. It should be offered to every suitable patient. So thank you very much. Stop slideshow. Thank you.